Hey everyone, happy Saturday, happy Mother's Day weekend. Welcome to my live stream. I'm Victoria Moll. I'm a medical coder, auditor, educator, content creator, and live streamer. And I am live just about every Saturday here, usually around 2 p.m. to do Q&A. Today we're going to be doing something just a little bit different. Instead of just going right into Q&A, I actually have some viewer mail today that I want to just kind of quick go over. And I want to do some medical coding news. I was able to find one coding update and then a couple of interesting articles that I thought would be really cool to discuss today on the live stream. So go ahead and say hi to all of your friends and say hi to me. We're going to have some fun today and just do real casual Q&A, but after we go over the live stream, I forgot to load up the, do you believe it? I forgot to load up the video for today. Just give me 1 second while I load it up, because we can't get started until we play the theme song, right? So here we go. You know what, this morning I was presenting for the Augusta, Georgia chapter. So that was really fantastic. So thank you a lot to the Augusta, Georgia chapter for having me. They had a really, really good presentation put together for their chapter. Where is my intro and cards? There we go. There we go. Now it's a party. All right. So, hey, everyone. Hey, Jennifer Kingsley. Hey, Mallory. I see you there. I see Nicole Workman is here. And it's so great to be here. You know, this is one of the... Marissa! Marissa made it! Hello, Marissa. Welcome to the live stream. I know you're usually out and about and doing all kinds of stuff. You're always having a good time. So I don't know if any of you guys noticed this, but I started posting in the video descriptions for my videos, my P.O. box. I've had this P.O. box open for a while, and I've gotten just about nothing in it, but I actually got a letter. I got my first viewer letter. I'm so thankful for Kara for writing in. It says, hey, Victoria, I wanted to write in and say how much I love your YouTube videos. I had a very difficult time taking the AAPC anatomy class, and you recently posted up book suggestions, which really helped me. Anytime I have difficult time studying, I keep watching your videos, and they inspired me to keep studying. I love the new videos you started with the CPC chapter review. Any videos you can post for beginning coders would be greatly appreciated. So yeah, I'm really excited. I'm wearing the same shirt that I did in the musculoskeletal video that I just did. So yeah, the video series that I'm doing now is going to be integumentary, musculoskeletal. Next is going to go into respiratory and then cardio. So just a real high level overview, kind of discussing what to look for, and then just a couple of case examples of things that I think are pertinent. They might be things that maybe get missed, some important guidelines to go over. And yeah, so thank you so much, Kara, for writing in today. And if anyone else wants to write in, I do have my P.O. box number on the video descriptions for, I think, YouTube and Facebook. LinkedIn cuts off the descriptions after like a certain amount of characters. So what was the next thing I wanted to talk about? News. So there's some coding news I want to talk about today. Let me see if I can bring up some of these articles. So I tried saving a couple of them as PDFs so that we can kind of look at them too a little bit if you want to, as we're going through some of these news articles. So first and foremost, there was an update from the AMA that they have some new codes for one of the new COVID vaccines that's coming out. So if you're not subscribed to the AMA news updates, it's something you definitely want to do, because they will send you blasts if there's like pertinent, pressing things that are happening. Like that's how I knew that the technical corrections for the 2021 guidelines came out right away, was because they have an email list that you can subscribe to where they send you alerts. So they just sent out a news alert that there are now CPT codes for the Novavax vaccine for COVID-19. So this is the category 1 code that we have for the med. So remember, when we're coding for vaccines, we're going to look for 2 codes. We need the code for the medication and the administration. So the actual juice that they're injecting into you, and then the procedure of them actually, injecting it into you. So there's 2 parts there. So in the case of this new code, this is the code for the vaccine solution itself, 91304, and that again is for the Novavax. And then we have 2 administration codes. So this is another 2-dose vaccine. So we have 2 different administration codes for the first dose and the second dose. So 0041A is our first dose, and then we have 0042A for our second dose of the vaccine. I'm trying to see if it has on here the effective date. So that's the one thing that I'm not seeing on here. Updated concept. So I'm guessing they're effective for use on the condition that so it's on the condition that it gets approval. So as soon as it's approved from the FDA. Now, keep in mind, they're not going to be in your CPT book because these are new codes that they've just developed. So once this is approved by the FDA, and they're starting to administrate them, these will be the codes that you can use. Make sure you write them in your CPT book in the case that maybe you get something and you're trying to look it up in your book and you're like, where the heck are these codes? They're not published in the book yet. So make sure you get them in your book. They're probably not going to test you on them in the CPC exam or any medical coding exams until probably next year, if they decide to add in some new questions based off of the vaccine coding. The next article, real short, let's see what we got. So CPT News, Dose 1, Admin. Just this quick update. Omega Healthcare has a new VP, Chris Rigsby. So congratulations to Chris Rigsby. They do a lot of risk adjustment coding stuff, it says. This one I found really interesting, and I want to talk about this. So this article says, and this is kind of an extreme, I feel, title. And this was published by, it looks like A to Z Family, News 3 on your side or something like that. And it says the cost of care, an estimated 50% of medical bills contain errors. So this is the interesting thing about this article. So this article basically surrounds a woman who is saying that she had a bill, the bill appeared higher than normal, and that she called the healthcare organization and they kind of agreed like, hey, yeah, that seems a little bit high for the cost of care for a couple of ultrasounds that she had. She had 2 ultrasounds. One of them, she says she called because it was about $600 and then the cost jumped up to $2,700. The billing office said it seemed kind of high. She thought they would kind of look at it and correct it, but then they kept sending her notices and potentially, I guess she was concerned about getting into collections. And what I found, and I'm not going to get too much into was this incorrectly billed or what have you for this particular article, but there's a couple, this is why I brought this up, is because this sensationalized headline, cost of care, an estimated 50% of medical bills contain errors. Now, if we look down here, the reason that that was said and put in the title is because it says that Caitlin Donovan from the National Patient Advocate Foundation says that medical errors are common, which we all know that. We know that it's pretty common. It's not that uncommon for medical billing errors to happen, coding errors. You know, even the best of us will slip up sometimes. But this person here, it looks like when I see here the words National Patient Advocate Foundation, I'm thinking these are probably fragile patients who are seeing a lot of healthcare providers. They probably have a lot of bills. So it lends to reason that people who are going to the National Patient Advocate Foundation probably already have a high healthcare usage and a more likelihood that they have billing errors because they're looking for some sort of advocacy. So this 50% of medical bills statement is actually just her saying that that's what she kind of estimates based off of what she says. So this 50% is not based off of data. It's not based off of, we took a sampling of 600 bills from across the nation. It's literally just this one woman who says that in her role at this organization, specifically as a patient advocate, she sees 50% errors. And I think that is kind of an unfair pool to kind of pull a percentage from for that title of 50% or more. So while I do agree medical billing errors can be high, I think that is a little bit sensationalized of a title. The other thing that I found interesting on here was they talked to, it says, Consumer Reports Chuck Bell. So this guy works for Consumer Reports. And he talks about how there's, problems with medical billing and what to do about them. And this I found extremely interesting. He said that if you, this guy from Consumer Reports, not a medical biller, not a healthcare professional, says that if you are having problems with your medical bills, the final thing you can do is go public, contact the media, go on Twitter and criticize the hospital that sent you too much of a bill, which is a great thing to be telling patients that if they're billed too much, you should just go on Twitter and criticize your healthcare providers and hospital organizations. While I can understand that in extreme circumstances, I'm not sure that's something that we should be advocating to tell patients. If your hospital's billing you too much, just go on Twitter and complain. So the last article that I think would be interesting, I don't know, what do you guys think about that? What do you think about shaming healthcare organizations if they've billed you too much? Because I think that's a slippery slope. I mean, I'm all about price transparency and all of the new initiatives that have come out of that, because it's very true. Like, there are some healthcare organizations that you step into and find out that they bill outpatient, they're an outpatient facility, and they're going to charge you that facility fee, and you think it's just going to be, a simple office visit charge, and it winds up being a lot more. So, it's a slippery slope, though, to tell people to just go online onto Twitter and start complaining about their hospitals and healthcare organizations and physicians and so forth. Now, this last article I want to talk about, this is something else. So this article, I'm like tapping right in the microphone. This one is about an 80-year-old patient. And let me get my camera over here. So it says 80-year-old Mary Flores says, and this is from Fox News San Antonio, says that medical staffers at Brooke Army Medical Center called for an ambulance to transfer her to a rehab facility. She has a heart condition, and the service was coded as a non-emergency transport. And she says she didn't know she had a problem until February. So basically, this 80-year-old woman has a heart condition. She had either some kind of flare-up or attack, was admitted to the hospital, and then they released her to a rehab facility, not to home, but to her rehabilitation facility. So she apparently was told by one of the nurses that she could not be transported to the rehabilitation facility from the hospital by private vehicle, that she had to go in a wheelchair, and that she had to go in an ambulance then with the wheelchair. So she, I guess, asked the nurse there, is insurance going to cover it? And the nurse informed her that yes, insurance will definitely cover you being transported to your rehab facility in your wheelchair by ambulance. So she wound up with this $800 and some bill, and keeps getting notices that she has to pay for this bill. And she's was told that this was not coded properly. So she went to the news to inform them that she's getting this bill because her service was not coded appropriately, because they coded it as a non-emergency transport. So I don't do a lot of ambulance billing. So I actually had to look this up. So when you look into some of the ambulance codes that we have here, they are all AO something or another. So they're like right at the front of the HCPCS book. And I don't know if any of you here do ambulance billing, but I would love some feedback on this because I thought this was an interesting case. So I'm seeing what they're talking about here. There's all these ambulance codes that are non-emergency transportation. Now, I don't know the difference between a non-emergency transportation versus other transportation, but to me, if a patient's being discharged from the hospital, they're fairly stabilized and they're getting to a rehab facility, that personally to me, and I'm not clinical, doesn't sound like an emergency. That sounds to me just like this, like it's a non-emergency transportation. That's what I would assume. Again, I don't know all the details about ambulance billing because that's not something I have particular experience in. So that's what but I'm thinking maybe something around here, non-emergency transport via wheelchair van, because they said that they transported her via a wheelchair by an ambulance. I don't know. But one of the things she brought up was she said that they coded it incorrectly as this non-emergency. And then they said that she was coded as the ride as a broken thumb, and they're not going to pay on a broken thumb ambulance drive. So let's actually look, because they, during the newscast, showed a little screenshot, and I'm going to try and zoom this in here, of her diagnoses, like from the bill. So if we look on here, we can see that we can't see the number one diagnosis, which I'm assuming since it was a heart condition, she has some kind of heart attack or episode, what have you, and that's what our first diagnosis is here. It's cut off. We have a UTI, N39.0. We have E. coli. We have repeated falls. And then underneath that is what she's talking about, because she's saying that they coded that she has a broken thumb, and she doesn't have a broken thumb. She wasn't transported because of the broken thumb. So first thing I'm noticing about this broken thumb, though, is that it says with routine healing. So this probably wasn't from this episode of care. This is probably a fracture that she maybe had something from something else, or it could have even been like a hairline fracture that maybe she didn't even know she had. It was, a more minor fracture. But the fact that she has repeat falls, it would stand to reason if she's repeatedly falling that she might have some kind of fracture on her thumb. The interesting thing, though, is I did know to pick this up. It also says she has age-related osteoporosis without a current pathological fracture. So this to me is kind of contradictory, that we have a fracture up here and then without current pathological fracture, because there's a connection between osteoporosis and fractures. So I'm thinking they probably should have coded this as the with pathological fracture. So then, she's got a lot of other stuff going on: chronic kidney disease, type 2 diabetes with nephropathy, polyneuropathy, hyperglycemia, all kinds of other stuff going on. So yeah, it is a little bit blurry because it's just a screenshot from the news video. I had to kind of screenshot it and put it on. But I think it's kind of interesting the way that, so first, here's my thoughts on this. This is my thoughts on this. First off, the nurse probably shouldn't have told the patient, yes, this will be covered by insurance, because not knowing the patient's intimate details of what insurance she has, what diagnoses they're going to be putting on the claim forms, I think it's inappropriate for anyone to just definitively say, oh yeah, this is definitely going to be paid. Second off, we also know, those of us that work in medical billing and coding, that more so on the billing side, that one of the things insurance companies like to do when patients call and complain about their bills is go, oh, well, you know what? Your healthcare provider, they didn't code it correctly. And if they'd have just coded it this way, it would have gotten paid. So I'm not saying that's exactly what happened in this case, but it's entirely possible, just in my forensic thoughts, that if we're looking at something where, this patient maybe called their insurance and said, I don't know, I have this $800 bill, they may have just gone, oh, well, if they'd have coded it as a non-emergency, we would have paid it. But maybe this patient didn't actually meet that criteria for the non-emergency ambulance ride, and she was just incorrectly told by the nurse that it would have been paid for. So to give kind of a more extreme example, Let's say, for example, I am a patient that has breast augmentation. So a breast augmentation in some cases will be paid, but if I want to have it just for cosmetic reasons, and they will use a diagnosis code that's basically cosmetic dislike or cosmetic surgery, and then use the breast augmentation code and submit it out to insurance. I could call my insurance company and go, hey, why didn't you pay my breast augmentation? I was told, breast augmentations are paid. And my insurance company could say, oh, well, if you had breast cancer, we would pay for your breast augmentation surgery. So in that case, they're basically telling me, oh, well, they didn't code it. They might say, oh, we didn't code it right. Now, I don't have breast cancer, so it wouldn't have been right to code it that way to get it paid. And that's where we run into some of these problems where these insurance companies are going, oh, well, they didn't code it correctly. But what they mean is they didn't code it in the way it would have gotten paid. And the way it would have gotten paid might not have been compliant with what the patient actually had and what their situation was and the codes that should be assigned for that scenario. So I don't know. What do you guys think? Do you think, first off, do you agree with me? Like, this nurse should not have said that this code should have been covered. And second off, my thought process is this was a situation where the patient got the bill, called the insurance, and the insurance said, oh, well, if they'd have coded it this way, they put this fracture code on, that's why we didn't pay for it, and kind of gave them a runaround. So that's my thoughts on that. You guys let me know what you think. So let's get into some question and answer today. Mary Ellen's providing some good information. So in PA, on hospital end, case manager or nurse needs to get a form of medical necessity filled out to say patient required this type of transport and why. So that is interesting. So maybe they are familiar with it and why they need the transport. But yeah, I don't know. I don't know a lot about ambulance coding. And I think to me, like when I think of an emergency ambulance transport, I'm thinking like the patient sawed their arm off, they had a heart attack, they, can't move, they broke their spine. I'm not thinking like they're being transferred from the hospital to the rehabilitation facility. Jennifer Kingsley's asking, I'm just researching which classes to take to become certified in medical billing and coding. It's kind of confusing, and I'm wondering which classes to take to be certified. There's several options. So you can go through local technical schools. You can go through community colleges. If you're specifically talking about the AAPC website, what I will say is, there's a lot of options to get certified there. As far as if you're talking about training on with the AAPC, versus AHIMA. So those are the two organizations that you want to look for certifications, AAPC or AHIMA. Nothing against any other organizations, but those are the ones that employers are looking for. So if you're talking about certification in medical coding, if you don't know exactly what the heck it is you want to do with coding, I would say always default to the CPC, because that is the one that's the most common. It's the one most requested by employers, is the CPC. So CPC is coding for professionals, or professional coding, which means coding for provider-based services. So surgeons, PCPs, internists, OBGYNs, all of the services that they provide. Outpatient coding does have some of that, but also coding for like surgical centers. And then inpatient coding is coding for hospital admission. So all the stuff that's going on during the hospital admission. And they use different code sets for inpatient. They use PCS. CRC is risk adjustment. It's just diagnosis coding. And then of course we have billing, auditing, et cetera, et cetera, et cetera. But this is what I would go for, is the CPC. So probably training through either your college or your local technical school, business school, and then prepare for certification through the AAPC, and their CPC certification is good. The comparable one that they have through AHIMA is the CCSP. So if you want to get certified through AHIMA, they have the CCSP for professional coding and the CCS for inpatient coding, but there's criteria that you have to meet to test through a HEMA. So if you don't have prior experience in coding or have gone through formal training, you have to get kind of a CCA, which is the Certified Coding Associate certification. I would rather just go through the AAPC. They have a lot more support. There's more CEUs that you can get easier for the AAPC, unless you already know you very specifically want to get into inpatient facility coding. That case, a HEMA is really more known for inpatient facility type coding. Melanie says, I just finished Practicode. Congratulations, because Practicode is a beast. It is a beast. I don't even want to ask you how long it took you to do that, because I'm sure it was tons and tons of hours. So I technically both knock off a year of experience, but do employers consider the 80 contact hours and completion of Practicode as relevant experience? So I talked about this a little bit. A couple months ago, I interviewed Bertram from Renowned Talent, and I asked him the same question because he is a recruiter. So he knows a little bit more about what employers are looking for. So there's two things to consider. First is the apprentice removal, and second is the experience. So there are some employers that will just say that they don't want to hire CPCAs. They'll say no CPCAs, don't apply if you're a CPCA. So having that apprentice status will qualify you for those positions that say no CPCAs, because you don't have your A anymore. The other thing to consider is, do they count it as experience? Most employers don't. So it will qualify you for more positions because you can qualify for the ones that don't want CPCAs, but they don't really count it as like actual coding experience the way they would for if you are working at a hospital or healthcare organizations in a coding specialist, coder role. So it's definitely going to get you a step up, but not necessarily count as experiences in the eyes of recruiters and employers. But yeah, so the 80 contact hours she mentioned was talking about the hours of education. So education contact hours are not the same as Practicode hours. Practicode is a separate thing. So 80 hours of education in medical coding will remove a year off of your apprenticeship status as long as it is approved by the AAPC. And you can prove it through maybe letterhead from your school. And then Practicode is a totally different concept. That is a module that you have to go through with redacted coding cases. And that will also take 1 year off of your 2-year requirements for apprenticeship status. So this is a more complex question. I'm looking for your insight on how you are determining the new guidelines for 2021 for further clarification on when to use systemic symptoms. Per the AMA definition, it would be used on an illness that causes systemic. But what if the patient has the illness but doesn't have any systemic symptoms present at the time of the encounter? Would you still code that? I would not. I would be looking for connection in the documentation that they have systemic at the time of the encounter, because the billing for that day is based off of the date of the encounter. So if they have systemic symptoms 2 days later or 4 days prior, it has to be on that date of the encounter for it to count for the medical necessity, at least based off of my interpretation. And I know that was, someone brought up a point to me the other day. I was looking at a case that I did on, I think it was some kind of respiratory and skin condition, and I didn't consider it systemic, but she's like, well, it could be based off of this AAFP thing. So I think there's probably some fine tuning that could be done specifically in that area with providers, providing some more linkage maybe between, the systemic symptoms, because There are some that I think are like general that aren't counted, like if the patient just has, a headache or body aches, and then there's some that, not having clinical expertise, you might not think, oh yeah, this is totally related. Like if they're having something of the eye and something of the toe, there could maybe be some clinical systemic reason for that. But, as a coder, it's a little hard to pick that out. A nurse auditor might, but maybe not your standard Jane coder. How do you list Practicode and online AAPC courses on a resume? I believe they said they are not to be listed under education. That's a good thought. Let me check. So I know I wouldn't consider it formal education, because to me, your education section is more so things that are formal education, like you went to a school or a university, or even in your high school. How to list it on your resume? If you have a skills area, you could maybe stick it in there. You could, if you have a summary, put it in there that you're a medical coder, that's completed your Practicode. But honestly, I think really what employers are going to hone in on is that you have the CPC versus the CPCA. And you don't have to wait for your new certificate to come in order for that to, be changed. As soon as you get that word from the AAPC, like, hey, you're good to go, you no longer have your apprenticeship status, you can change, your title in your LinkedIn title. You can change your resume and have it just say the CPC, because what they'll do is they'll verify it on the AAPC website, and they can see if you're a CPCA versus a CPC. There's what they do is employers will go to the main AAPC website, and at the very bottom here, this is what they use for credential verification. So when they ask to verify your certification, they can do it two ways. They often ask for the member ID because that's the easier way to do it. And then they'll pull it in by your last name or your email address and last name, and that will show. So if you do, hold on a sec. Let me pump mine in here so I can show you. Because I don't want anyone knowing my personal email address. Like it's not listed, probably somewhere else. Verify now. So yeah, if you type in my email address and my last name into the AAPC website, it'll show you all of my credentials and the exact dates that I got them, and when the renewal dates are and if they're active. So as soon as they make that switch from you to a CPCA to a CPC, it'll show up here, CPC, and it'll have the date that you earned it, and it'll be the date that you passed your exam, and then what your renewal date is and that it's active. So that's how recruiters verify you. So they don't, a lot of people get confused and they're like, I haven't gotten my certificate yet, and they need to verify my employment. As long as they have either your email address that you're registered with at the AAPC or your member ID number and your last name, they can just look it up on the AAPC website. Diana says, I'm in a rural community. What accreditation do you recommend that I get for that reason for medical coding? I always recommend the CPC because that is the best starting credential. Now, with AAPC, you can get any credential to start with. You don't have to go in any sort of order. If you just want to get your credential in compliance or practice management or even just auditing, I have seen some people that don't even have the CPC or COC. They just have the auditing credential. But that's what I would suggest, is work towards your CPC. So that's this one right here. They have all kinds of different packages all the time about, today we're going to give you, or this week or this month, we're going to give you free practice exams. We're going to give you additional books. We're going to give you whatever. Right now it looks like this is exam prep. Excuse me. So if you're not going through a school that's going to get you midterm out of the way, any kind of office certifications, A&P, medical Terminology and anatomy courses are available through the AAPC. There's all kinds of bundles they have that you can get. So right now the CPC, I know last month they were having a scholarship program. Let's see what they've got now. It looks like they're having a sale, packages and pricing. So yeah, so it varies a couple $1,000s. So if you're just looking to do the self-paced course just on medical coding all by itself, it's about $2,000 right now, and it goes up to almost $3,000 if you want live instructors, if you want to add in the Practicode, if you want to get your code books included, like this would be the full package. But what you can do too is, so see Diana here saying she's in a university for certification right now. Yeah, so if you're in a university, that's great. What you can do is, if they're already teaching you then MedTerm A&P and medical coding and all that stuff, as what I would recommend if you go through a university is take a couple practice examinations. Like go on the AAPC website and buy some practice examinations, or you can get them on my website and a couple other websites too. See how you're doing. If you can get like an 80% on a practice exam, like you're good to go. You can go sit for your CPC certification. If you're not quite at an 80%, there's review classes you can take that are cheaper. Sometimes the local chapters will even have review classes. There's one out in Harrisburg. They have a presentation that an instructor put together that they utilize, that they do all kinds of stuff. Like they have this huge team approach on doing preparation for CPC. So that's fantastic. And there's all kinds of stuff like that then you can do to just almost prepare for the exam after you've gone through all the training at your university. Lisa's are saying, now it seems like it's impossible to find jobs in coding without experience. Did I make a mistake? I have 15 years of medical experience. I'm not going to say it's easy, but it is absolutely out there. There's tons of medical coding jobs. They do oftentimes ask for experience, but really just start applying everywhere. I wouldn't exaggerate or tell non-truths to recruiters and so forth in order to get in front of them. But it is sometimes difficult. I have videos that you can check out on the channel on alternative jobs for medical coders. So jobs that aren't necessarily the title medical coder, but will utilize your skills in ICD-10-CM and in CPT. So they are out there. There's also a video I have on the channel about where to find a medical coding job, how to get medical coding jobs. Getting your resume done also sometimes can increase your chances if you want to go out with Project Resume and get your resume professionally done. But, you know, this is not just a medical coding thing. This is just about every industry out there right now, with maybe the exception of nurses and doctors. You know, every other industry, I can't tell you how many videos I see anymore on TikTok where people are saying, you know, I went out and I got a bachelor's degree and I have a master's in psychology and I've written all these journal articles, and they're still only being able to find like entry-level positions with, you know, not even in their particular fields. Either the job market is just really, really tough right now. Life of Sunshine on Wheels, is it best to start with an internship? Yeah, you know, that is a great thing if your school offers you an internship program, because internships do count as real life experience versus like a Practicode where you're just kind of coding cases. I was hired off of my internship. I'm a proud community college girl. I started out in web design in community college. A lot of things happened, wound up dropping out of college, getting data entry jobs, secretarial jobs, all kinds of odd office jobs, and then decided to go back to school for medical coding. I don't even have an associate's degree program. I have a community college diploma, actually, and just made the best use of every advantage that possibly came my way. So I was hired off of my internship. After I finished my program, I was sent to a billing office for a local hospital. I did charge entry. And I did charge entry for a couple of years, I think, until I was able to get then into the billing office. And then finally my first position in actual coding. So yeah, if you can get an internship, there is a program that the AAPC has. Let me see if I can show you how to find it on the website. I know that they have it. I just don't know where to find it all the time on the website. and it's called Project Extern. Let's see if it's on here. It might be one of those things that I can only show you if I'm logged in. Let's see. Resources, medical coding jobs, mentorships. They do have a mentorship program. Oop, I can't see it because my face is in the way. They do have a mentorship program too, which might be helpful to some of you that are looking for some professional guidance. Where is the Project Extern? I can't find it. Other resources. Oh, there it is, Project Extern. So here is where you can go on the AAPC website and see if there are externship programs in your area where you might be able to get some experience. Mary Ellen's asking me to explain what charge entry is. So they don't do this too much anymore because of how much EMRs have advanced. But back when I started, I had 2 computer monitors, not terribly unlike what I have now, but instead of this one being landscape, it would be portrait style. And I would have 2 monitors. So this one would have my practice management system in it. And this one would have what we called super bills. So the provider would have a list of all of their commonly used CPT and ICD codes. And they would go, okay, I did this one and these diagnoses. And they would just circle them and scan them in. And then I would get them in the billing office. And I would sit there all day long with the super bills over here and my practice management system over here. And I'd go, okay, the provider billed in 99214 and diagnoses. Oh my gosh, it was ICD-10 back then. Let me try and remember. 401.9 was ICD-9. And then I, check the patient's information that it was all correct and the insurance was in. And then I'd send it on its way out the door to the insurance company. And then I go to the next one and punch that one in. So that's what I did all day long. I just entered all of the coding charges and sent them out to insurance. So it was nice because it got me familiar with codes. I started, kind of seeing, oh, well, this procedure code usually matches up with these kind of diagnoses. And after that, I started working on things like implementing charge scrubbers. I started working on special projects, like anything that they were like, we need a volunteer. I'm like, I'll do it just to start getting kind of my feet wet in there and building some experience and credibility. But yeah, I was in charge entry for a couple of years before I moved on to AR. So the organization I worked at, I had trouble moving up. And so I was in charge entry. I don't remember, how much did I make in charge entry? I want to say I made like $15 or something like that an hour in charge entry. And that was back in those like 12, 13 years ago. But I had applied for AR positions. I had applied for lead positions. I had applied for, I think, a liaison, a couple other stuff, practice man, anything. Like I was applying for anything. And just opportunities were just not at the right time. I took a second job teaching classes at a local technical school. I taught medical insurance. I taught intro to coding, advanced coding, and intro to health information technology in the evening. And as I was growing and opportunities were not coming up at my day job, I finally just decided, it was time to move on to something else. And I was able to get a job in the billing department doing accounts receivable for another organization. So yeah, it's nice. So yeah, no, charge entry is not the same as charge master. Charge master, I don't know a lot about what the charge, I know of the charge master. I know they're in charge of this CPT code is this fee and making sure that the charges are associated with the right codes and that, they change appropriately if modifiers are used or locations are changed, what have you. So yeah, I don't know. I don't know what about, I don't know a lot about the charge master. I know the last organization, all the charge master people seemed very techy. I'll tell you that much. They knew a lot of technical stuff about the EMRs and stuff. Fahim says the China rocket is falling down. Is there more important news we should be watching other than me right now talking about my charge entry positions? I heard a little bit about the China rocket thing, that there's something up in space that's coming down and we don't know where it's going to hit. That's what I learned on TikTok last night. Jennifer says, it seems you need a lot of extensive computer skills for medical billing and coding. Can you suggest how to get those skills? So I wouldn't say a lot of extensive computer skills. Basic office skills. So if you know most of the Microsoft programs, Microsoft Word, you probably won't need to use PowerPoint too much right away unless you're going right into education or they ask you to put some slides together. So Word, Outlook, you'll probably have to do your email via Outlook. A little bit of Excel. So spreadsheets won't be too bad because you're not going to need to know how to make pivot tables and all of that right away. Usually what we do with spreadsheets in medical coding is maybe they might send you a spreadsheet of here's all the cases you need to code, or here's some cases that we need you to take a look at. You might have to enter in some comments, manipulate a little bit of data, maybe filter, but not anything super crazy. So if you can just get some basic computer skills, sometimes there's LinkedIn classes you can take on some of those things. The other thing, they do get technical as far as EMRs. The hard thing there is you can't really oftentimes train on the specific electronic medical records unless you work in an organization that specifically uses those programs. So like Epic. In order to get Epic certified, you almost have to work in an organization that uses Epic, and then we'll send you to Epic headquarters to get certified. Actually, I don't know if they still do that right now with COVID and so forth. Maybe they do it remotely. Someone told me that there are some YouTube training videos on Epic, which is it's probably the most popular EMR that healthcare organizations use. So that's what I would start out with, your basic Microsoft Office packages. And then if you can just go on YouTube and see if they have some videos on using the Epic EMR system. I haven't looked myself, but apparently there are a few. Richard, hi, hope you're doing well. Well, should I start with learning about medical terminology and physiology? I just finished on grade 12. If you're looking to get into medical coding, that's the best start that you can make, is learning med term and physiology, more so the med term than maybe even the physiology or anatomy is important too, but med term really is the key. Yeah, I actually have a video about my med term suggestions. This is the book. This is the book that I love for MedTerm. I think I have this linked in the description. And this is Medical Terminology and Anatomy for Coding. If you're going into a program where you're specifically like an associate's degree for medical billing and coding or a diploma program, they'll usually include MedTerm and anatomy and all that stuff. But this book, like if this isn't the one that they give you, you probably want to get this book anyway because it is phenomenal. It gives you all kinds of cases where it ties in the MedTerm and anatomy to the medical coding piece. So yeah, that's where you want to start next, MedTerm. If you're looking, there's lots of options to learn MedTerm, and I have a whole video about it. Let me see if I can pull it up. I think it's just called MedTerm for Coders. And a lot of people have given feedback that it really helped them out because I give all the budget-friendly ways that you can learn MedTerm. Let's see here, your channel. It should be right here-ish. No? Let's see. Let's go videos. There it is, MedTerm for Coders. So yeah, so if you're looking for, you want to get ahead, maybe even if you are taking a MedTerm class, there's lots of resources in this video that you can check out where I talk about all the free and cheap resources for MedTerm. Yeah, Mallory's saying you can get MedTerm and a physiology course as an add-on when you sign up for an AAPC. So if you're going through the AAPC for all your training, yep, you can add that right on as one of your additional courses. Willis is saying, I have bad eyesight and I have a big external monitor hooked up to my laptop. Is an external monitor allowed for the exam? If I remember correctly, you're only allowed one monitor. So I would check with the AAPC, call them directly, because I don't know if they are accommodating anything like that as far as ADA accommodations, or if there's maybe a way you can hook it up so that everything's on one monitor. But to the best of my knowledge, you're only allowed one monitor. Last I had heard, there were some people who said that they did have 2 monitors and they had to have the one disconnected. This book, I don't know if it's on Barnes & Noble. I got mine from Amazon. So I do have a link for the Amazon one on the website, but I don't know. I don't know about Barnes & Noble. Maybe not, because my guess would be they'd have more just generic med term type books as far as, and not this one very specifically for medical coding, but you never know. You could probably order it from them. What tips can you give for finding a job after receiving your certification? I have been working in healthcare and scrubbing encounter forms for coding errors, but not sure how it will transfer. That's going to transfer like heck. So that's one of the things that I've worked on in the past. I've had other coders work on in the past, because it familiarizes you with the codes. You can see the codes and recognize like, oh, this CPT code and this diagnosis code, they aren't covered together. So you're familiar with even some of the policy guidelines. What you need to do is really make sure that you are like highly emphasizing that on your resume. Like, I have expertise in charge scrubbers and utilization of payer policies as they pertain to CPT and ICD-10-CM mismatches. Like, really hype that up on your resume, because there's a lot of people that don't know that they don't know some of those edits that are in place. And you have an advantage there because you know how the claims will look. I don't want to say this incorrectly, how the claims should look in the situation in which they get paid. Not that we're necessarily going to only code them in the way that they get paid, but what you should be looking for things that will get it paid, and then possibly like going back to the provider and going, hey, Capital Blue Cross doesn't pay for these. Does the patient have something else? So that there are lots of ways that can play in. Kim, this is a great question. Do you have any videos on coding vaccines? I do. It's an older one. When to use Z23? Almost every time you use Z23, unless it's for a non-prophylactic, like if you're giving a tetanus shot because the patient stepped on a rusty nail, that would be maybe a situation where you wouldn't use Z23 because it was because of the wound. But yeah, I have a video that's about 90471, 90472, the PEDS vaccines. It's an older video, but it still is pertinent. Well, let me see. The only thing that wouldn't be covered in there is probably the COVID stuff. Yep. It is right here. Medical Coding Vaccine Administration. So that's the video you want to look for. It's from 9 months ago. Carol's asking, can you describe what charge scrubbing is and how you do it? So say a provider bills out, because it's not uncommon that providers will pick what they think the right diagnosis and CPT codes are and send it out. What will happen is they put edits in place that say, hey, they'll put edits in place that say, for example, we're billing for a surgery for carpal tunnel repair. They're going to look for a carpal tunnel diagnosis or some sort of wrist-related diagnosis because that's what the insurance will pay. So they'll build an edit in the electronic medical record or practice management system that says, hey, if you're billing for this CPT code, check to see if it has these coordinating diagnoses, because these are the ones that are going to get paid. So someone will maybe get a work queue or some sort of, prompt in their system that it will get reviewed by a coder or a biller or someone that says, hey, we've got this carpal tunnel procedure code, but the diagnosis code isn't one of the ones that are covered. Are you sure there's nothing else in the documentation that is one of these codes that get covered? So that's what charge edits are. They're things that are programmed either based off of insurance regulations or Medicare guidelines that say, hey, this CPT and this diagnosis code don't match. Should we still push it out to insurance? Should we change it? Are you sure that these are even the right codes? Maybe you should double check that. Or it could be mismatches, even things like maybe a gender mismatch or an age mismatch. So we have preventative medicine codes that are based off of a patient's age. So there might be an edit in place to say, hey, if you're billing the preventative medicine exam for a pediatric patient and this patient's age is 56, like, hey, that doesn't match. Do you want to look at this? Like, is the patient's date of birth correct? Did the CPT code get selected incorrectly? It could even be new versus established, that maybe it looks in the EMR and can tell that they have had visits in the past and they're not a new patient and it was billed out as a new patient. So that's what charge scrubbing is. There are edits in the systems that help scrub the charges. Usually they don't automatically do it themselves. There's like a human interface that looks at them and goes, oh, okay, I need to change this. I don't need to change this. We're sending it out. We're not sending it out, etc. So that's charge scrubbing. Love your integ and musculoskeletal review. When is the respiratory and cardio going to be out? Hopefully soon. So I have 2 videos coming up. What do I have planned? So I'm trying to get the respiratory one together. I tried to get someone to outsource to give me some respiratory and cardio cases so that I can use some custom built kind of notes that we could code off of. I haven't heard back from them yet. They're supposed to get them to me today so that I can get the slides together. So I'm really, fingers crossed, hoping that I'll get the next one, which would be respiratory, out this week. If not, it's just going to have to get pushed back till next week. So an MSDRG is a Medicare severity diagnosis related group, and that's how they get paid on the inpatient side. So I don't know a lot about inpatient coding because I mostly have worked with provider services, so billing for surgeons and internists and OBGYNs and all that cool stuff. So in the hospital setting, they're paid in the inpatient perspective payment system based off of a DRG, which my understanding is it functions like a group of diagnoses. So instead of saying, hey, this patient had this and this and this and this and this and this and this, and this is your payment, it's this patient came in and they had sepsis and they had congestive heart failure, and that all gets into this MSDRG, this group of diagnoses, and this is what we pay you for that. So not necessarily because you had like a 10-day stay or you had this amount of services, it's based off of your diagnoses. And I think the reason that Medicare does that is so that there's no incentive to do unnecessary testing, to do all kinds of, extended stays, because they won't get paid extra because they just get paid based off of the diagnosis group. Like, we know that the patient who has these conditions, the average cost is this, and this is what you're going to get. That's my understanding of it. Again, I am not the expert on inpatient coding, but that is kind of what I've inferred from various discussions that I've had or participated in educations. Victoria's courses and practice exams are super. I watch with my manuals open and take little notes when she tells us to. Yeah, I have practice exams and courses on my website for those of you that are not aware. And I actually totally forgot to even mention that. My boot camp's coming up in June. Why does it say not secure? Interesting. But yeah, if you go to contempocoding.com, I have all kinds of courses available. Right now, I'm still trying to get that CPC course together. That is just a doozy. But I have risk adjustment. I prep for the CRC credential. I have a boot camp for people who are already familiar with medical coding and just want to learn about risk adjustment in a more condensed fashion. Then I have a review for that. I have the CPC review and practice exam. And then I have some stuff just on E&M. Let's see, 5 stars. ICD-10-CM essentials. Let's talk lesions and modifiers for the medical office. I'm going to put together a couple more free CEU courses, and I'm debating what I want to do because I have 2 ideas for them, and I think I almost want to make one exclusive for my awesome channel members who have joined channel membership, and they pay either $1.99 a month up to $9.99 a month to support the channel and all the services that I provide. So I have a couple of things planned for diagnosis coding, because I heard that there's a need for some sequencing videos, like how do you figure out which diagnosis codes go first and so forth. So it's 3 o'clock. I'm going to take one last question. Mallory, I don't have prior healthcare experience, so I felt it would be beneficial to take the EHR and EMR specialty course on AAPC. That is a good idea. I didn't even realize they had that. Where is that? I didn't even realize they had that. Should I include the completion of that course on LinkedIn and or my resume? It depends on what your resume looks like. I think if you have a skills section, that might be a place to put it in. As far as coursework, I wouldn't know where to put that in on LinkedIn, because it wouldn't go under the yeah, I'm not sure. It wouldn't go on the LinkedIn under your school education. Maybe, do they give you a certificate of completion that maybe you could put it there? Those are the only things that I could think of. I am going to take this one last question that came in, and then I'm going to be getting out of here. So I have a question here about, you're in Pakistan, you're aiming for the CPC online exam, but there are no centers in Pakistan. You're scared by the time you're fully prepared that the AAPC closes. So I don't know. I only know what goes on with the AAPC, and it sounds like you're probably working with AAPC Global since you're in Pakistan. I know that there's no intentions for the general AAPC to close online exams ever, like they're not going back. As far as AAPC Global, I have no idea. So I would call and check with AAPC Global directly, because only they can advise on that. But my understanding from the main AAPC corporate office, not the global office, is that there is no intention to ever stop online certification exams. That's not like we're only doing this till COVID, and then when COVID's over, we're going to change it. There's always going to be an online option for the exams. So can you work in UK after becoming a CPC? I'm not sure what coding they do in the UK, because I'm US based. So I apologize. I'm not sure about that kind of scenario, because I'm not in the UK and don't have a lot of experience with UK. So everyone, guys, thank you so much for hanging out with me during my live streams. It is just so great to hang out with you guys every single week and just answer questions and chit chat. I'm actually thinking one of these days I need to set up like a Zoom call, just like a hangout, have coffee, coder Zoom call, maybe just for like channel members only. We'll see how it goes. And for those of you who are catching this on the replay, hey, let me know in the comments below if you enjoyed the video replay. I will see you guys next week. And until then, you just keep on coding on.